Hello everyone. Today in this video we are going to discuss one of the rare cause of cyanotic heart disease, that is hypoplastic left heart syndrome. In this disorder, what happened? There is a hypoplasia of the left ventricle. What does it means? Normally the heart having four chamber. That is a normal heart, that is a right atrium, right ventricle, and left atrium and left ventricle. In this hypoplastic left heart syndrome, there is a atresia or there is a absence of left ventricle, that is physiologically and anatomically there is a absence of left ventricle. Normal heart, what does it happen? In normally all the deoxygenated blood are coming from SBC and IVC and enter into the right atrium. And then deoxygenated blood enter into right ventricle, and from there it goes to pulmonary artery, and from the pulmonary artery it enter into the lung, and from the lung it is oxygenated, and this oxygenated blood enter into left atrium, and from which it goes to left ventricle, and then aorta. This oxygenated blood supplies all the bodies. But in case of hypoplastic left heart syndrome, there is a absence of left ventricle, so all the oxygenated blood which come from left atrium cannot go into the left ventricle, as there is a no left ventricle is there. So all the blood is not, the oxygenated blood is not enter into the aorta, and the child is suffering from cardiogenic shock or afterbirth, or the child is suffering from circulatory failure and severe cyanosis after birth. So how does the child will survive after birth? I will discuss in my later on. So this is called hypoplastic left heart syndrome. That means there is a absence of left ventricle. So what is the pathophysiology? So this is the pathophysiology, as I mentioned in my earlier slide, that normal heart, all the blood enter into right atrium, deoxygenated blood enter into the right ventricle, and from which pulmonary artery it is oxygenated in the lung, and then the oxygenated blood enter into the pulmonary vein, and then into the left atrium, and from the left ventricle it enter into the aorta and supply all the bodies. But in hypoplastic there is a aplasia, or there is a absence of left ventricle. Small left ventricle is there, so no blood is oxygenated blood enter into the left atrium, but it cannot go into the aorta via the left ventricle. So how does the child will survive after birth, and how does the child is survive in utero? Normally in utero, all the blood is oxygenated and deoxygenated blood is purified by the placenta, and all the oxygenated blood is entered from the umbilical vein and goes into the right atrium, and from the right atrium most of the blood enter into the left atrium, and from the left atrium this blood enter into the left ventricle, and then aorta, and then all the branches. But in hypoplastic left heart syndrome, there is as I say, absence of the left ventricle. So in utero, most of the blood is enter into the left atrium, is not goes to the aorta, but small amount of blood enter into the right ventricle, which is goes into the pulmonary artery, and there is a presence of ductus arteriosus, and this, as the in the utero the lung pressure is much more, that means PVR, it means pulmonary venous resistance is much more, so blood from the pulmonary artery enter into the aorta, as there is a, so this is most of the blood enter into the, in hypoplastic left heart syndrome most of the blood enter into the right ventricle. From the right ventricle the blood goes into the pulmonary artery, and as the pulmonary artery pressure is much more than the aorta, as because the left heart is aplasia, so aortic pressure is low, so most of the blood from the aorta enter into the, most of the blood from the pulmonary artery enter into the aorta, and that's how the child is survived. The aorta supplies is the all the body's part, and also it gets retrogradely to supply the brain also. So there is a mixing of blood is there, but most of the oxygenated blood enter into the aorta by this in utero. But after birth, when there is a blockage of the PDA, so if the PDA is blocked, there is no right to left shunt is happened, so the child will survive, is unable to survive until there is a PFO or ASD is there. So PFO or ASD they must be there, because most of the blood from the left atrium now enter into the right atrium via the PFO or ASD, and this blood enter into the pulmonary left right ventricle, and then the pulmonary artery, and the pulmonary artery from which it enter into the aorta via the PDA. So it is a duct dependent circulation, and the duct have to be patent for the survival of the child. If so, after birth, PDA should be there. PDA, if the PDA is not patent, then have the child will having circulatory failure. So PDA must be there, and the cyanosis is mostly depend upon the size of the ASD. Why? Because if the ASD size is much more, then more amount of blood from the left atrium enter into the right atrium. So if the size is much more, that means there is a good mixing, and the blood, the oxygenated blood and deoxygenated blood is mixing is there, and the cyanosis is decreased. But the child having as the high much more blood enter into the right sided, so there may be a pulmonary edema. So if the ASD size is much more, then the child is having low cyanosis, but the child having pulmonary edema, and the child may present with pulmonary right heart failure. If the size of the ASD is low, that means small ASD is there, then small amount of oxygenated blood enter into the right side, and this causing increasing the cyanosis. So PDA must be there to survive for the survival of the child. So how the clinically present? The clinically present is there is a circulatory failure just within after birth, or the patient may having cyanosis, and this cyanosis depend upon the size of the ASD. If the ASD size is much more, if the size of ASD is high, then low cyanosis, and if the ASD size is low, much more cyanosis and circulatory failure. Why? Because if the PDA is getting blocked, and then there is a no blood enter from the pulmonary artery to the aorta, and there is a complete circulatory failure. So the child is suffering from circulatory failure within just few hours after birth, or metabolic acidosis. So these are the clinical features of hypoplastic left heart syndrome, and as there is a increased blood flow to the right from the left to the right, and there is increased blood in the right ventricle, so there is a increased blood in the pulmonary artery. So it is a plethoric lung. So lung in X-ray, plethoric lung is there, and in echocardiography is the investigation of choice. Now the treatment, as it is a drug dependent circulation, so prostaglandin agonist is the first treatment of choice. We have to give to maintain the ductus arteriosus patent, and also we do the balloon septostomy. Why balloon septostomy is we have to do? Because if the ASD or PFO is not there, then there is a no mixing of the blood, and so the child will getting more and more cyanosis. So we have to do the balloon septostomy. After that, we go for the surgery. And surgery is no-root operation, no-root procedure. What is no-root procedure? As there is a hypoplasty of the left heart, as there is a no left heart is there, hypoplasty of the left heart is there. So what happened? So the aorta is also hypoplastic. So what we are doing? We are cutting the pulmonary artery, the main trunk of the pulmonary artery. It is cut, and we are cutting the pulmonary artery, and we make a cut in the aorta. So the pulmonary artery is now connected with the arch of aorta, and the pulmonary artery is attached with the left ventricle, pulmonary artery attached with the right ventricle, and we do a ballothoracic shunt. So in what happened? First is the cutting the pulmonary artery, then we attach the pulmonary artery main branch with the arch of aorta, and there is a ballothoracic shunt. This is called no-root operation. So this is for the aplastic left heart syndrome. Thank you.